Thank you very much, Dr. Rosenthal. Let's move to the next presentation. Dr. Ferrán Roses from Hospital Universitario Vall d'Hebron de Barcelona is going to talk about CRT therapy in pediatric age.
Perfect. So thank you very much to the organization for inviting me here today as well. We're going to spend the next minutes just talking about CRT therapy in children mostly, even though I'm going to talk about adult congenitals a little bit as well. So we are in an adult EP meeting, so I'm not going to talk about the indications for CRT therapy in the adults, but we know that patients that have left bundle branch block, broad QRS complex, and they have kind of a bad functional class, they will benefit from CRT therapy. And this is what is reflected in the guidelines. But still, there are quite a lot of patients that actually don't respond very well to CRT therapy, and one has to think why this is happening. And identifying those who are not going to respond is still very challenging. To be honest, I think that the causes might be just because the actual mechanism for this synchrony is not influenced by what we're doing. This must be one cause. And the other one is that even though the mechanism is the appropriate one, the therapy that we're delivering is not either appropriate or optimally delivered. So therefore, further evaluation needs to be done to understand the electrical mechanical activation of these hearts in order to actually improve the results of our CRT therapy, basically. But children are not little adults, and this is extremely important to remember. I'm going to explain to you the difference and the reasons why. So approximately 70% of the patients that we're going to use a CRT device in children have a congenital heart disease. And therefore, they will require multiple surgeries for their congenital heart diseases. And the population will have a higher percentage of right ventricular failure, and most of them have right bundle branch block rather than left, which is a difference from the adult population. To be honest, the typical scenario of heart failure that you would find in an adult patient, so left bundle branch block and ejection fraction of less than 35%, only represents 10% of our patients with heart failure. They all have shorter QRSs, and it's really uncommon that the underlying cause is ischemic cardiomyopathy, so really different from the adult. And the last thing that is very important, it's well known that a functional class in babies, in children, doesn't really correlate to the ejection fraction in the echocardiogram. Therefore, using the functional class as an indication in this patient might not even be appropriate. So this has already been reported in a paper. This is a paper from 2013 that actually adult definitions for indicating CRT might not be appropriate in children. We all know that congenital heart diseases are kind of a very heterogeneous group. There are fallots, transpositions, ABSDs, many different conditions that they all have different strategy treatments, and therefore also the outcomes might be quite different. So since I would say the last 5-6 years in the pediatric cardiology world, there's been the idea that we need to select our patients properly in order to deliver an acute or at least a good CRT therapy. And this is going to show you the proposed methods that actually are causing these ventricles to fail, and all of them require different approaches when we actually apply CRT therapy in these hearts. I'm just going to talk 1 minute of this mechanism because I told already that it's extremely rare in children, but the one that is very similar to the left bundle branch mechanism is the right ventricularly pacing LV dysfunction induced mechanism, which is probably the most important in our group. Then we're going to spend a few minutes just talking about the right bundle branch block and failing right ventricle, which is mainly for the patients with fallot. And I'm just going to give you some data and some results of the last two groups, which are still very challenging in our populations. So what do we know about CRT therapy in children? So these are the main studies that have been published about CRT therapy in children. As you can see, they are quite old right now, and the number of patients are just a few hundreds, no more than that. The congenital heart disease population is about 70%, as I said at the beginning of the talk. And what is important is most of those patients are upgrades from single chamber or dual chamber pacemakers. And as I already mentioned, the New York Heart Association function class 3 and 4 was only present in about 2/3 of these patients, no more than that, like it would be in the adult population. Ejection fractions really very low, and QRS is quite broad in this population. What happened to the technical aspects of our patients? So only about half of them would have a transvenous system, and the other one was epicardial. And Eric has already mentioned the problems of going epicardial in this sort of patients. And if we have a look at the outcomes, despite how heterogeneous these patients are, the results are pretty good. They are actually much better than in the adult population. So this is the results of the 3 studies I showed you. It's about 90% of patients respond to CRT therapy. They get shorter QRS durations, clearly the ejection fraction improved, and the functional class got better as well. In these 3 papers, they identified 2 good factors, so 2 factors that predicted good response to CRT therapy, and one of them is upgrading to a CRT P device coming from a right ventricular pacing, and the other one is patients that have a systemic left ventricle. And interestingly, patients who were had a CRT therapy because of primary DCM, those didn't respond well to this therapy, and this is clearly different from what it's advocated and said in the adult population. So let me just show you 3 examples of CRT-P mechanisms that I think are important. So this is one patient, a 16-year-old boy with conduction disease. So he had complete heart block and left bundle branch block. So you can see his echocardiogram is basically not good. His ventricle is dilated, the ejection fraction is about 40%, and you can see that the septum is doing funny bits and pieces in his echocardiogram. I wanted to show this echo because I think there are lots of ways of trying to identify which patients are going to respond and which patients are not going to respond. But there is this kind of a new concept of what is called septal flash, which it's very easy seen in the M mode, so you don't even need a speckle tracking or any sophisticated method to actually identify these things. And it reflects the early activation of the septum because of this left bundle branch block. And this has been studied by bar visions, and this mechanism is being described as the mechanism that is causing the left bundle branch block dysynchrony in these patients, and also they are the ones that will respond better, and they are super responders when you apply CRT therapy in them. This mechanism is very similar to what we cause to our patients when we pace them from the right ventricular apex. So one could expect that these patients will respond very well to CRT, and this is exactly what we're seeing. Let me show you one little baby. So she was paced when she was 1 year old for a congenital heart block. We at the Brompton used the same technique that Eric has described, so you can see it's pretty much the same chest X-ray. She was followed up at the age of 4. You can actually see that her ventricle is getting dilated, the function is really bad, the patient wasn't growing properly. And again, I just want you to have a look at the septum. The septum is doing a very funny movement. And when you analyze this with the M mode, you can see that there is a septal flash. There is this very fast movement just coming in. And this is her echocardiogram when she was 7. And as you can see, she was very sick and already got nearly into the transplant list. So this mechanism is exactly the same that it's been described in the true left bundle branch block in the adult population. So when we upgrade her to a CRTP device, you can see that just the same day that we put the CRTP device, the septal flash is gone. So we've resynchronized this ventricle from the very first day, and her echocardiogram 6 months afterwards doesn't show any evidence of the synchrony. And obviously you can use all these new techniques to show pretty images, but the thing is that this ventricle resynchronized very well and the patient is doing much better. If we move towards the third group of patients that are extremely challenging these days, are patients with right bundle branch block and right ventricle failing because of that. And this obviously means talking about tetralogy of Fallot. In the audience, everyone knows that Fallot is a BSD associated with pulmonary stenosis and the aorta overriding. And what the surgeons do to repair this patient is close the BSD and put a patch in the right ventricular outflow tract. These causes, in most of the patients, right bundle branch block just after the surgery. And they lived with this right bundle branch block forever, basically. And just recently, this is a paper that has been published by the same group that described the mechanism of true left bundle branch block patients and the mechanism why the patients with left bundle branch block would have poor function, but just in patients with right bundle branch block. And what they described is what they called a right-sided septal flash again. So you can see this is just using a tissue Doppler, but this dot here put in the septum, which represents this, shows a very early activation of the septum compared with the basal lateral wall of the right ventricle, which is contracting really, really later. And that causes a desynchrony in this ventricle, which might be an explanation why these patients do worse and that those ventricles dilate so much. Also, this is a very recent paper published by the group in the Heart Hospital by Pierre Lambiase, where they actually studied electrically how these hearts would actually activate during the time of a pulmonary valve replacement. And as you can see, the apex is clearly activated earlier, and there is a clear delay between the apex and the outflow tract of these ventricles. And one could think, okay, I want to resynchronize these ventricles. How am I going to do it? So you don't need a three-chamber leads, three-chamber system to do so. As long as you actually resynchronize the activation pattern that goes cell by cell coming from the right ventricular septum up, and you put a new lead in the outflow tract of these ventricles, you would be able to resynchronize them very well. This theory has been tried already in pediatric population. We know that for a paper that was published quite a long time ago, 15 years ago already, for Jan Janusek, where he actually demonstrated that when patients after a Fallot repair were paced DDD with the leads put in the right ventricular free wall, they got really better during the post-operative time. They got better DPDT, they increased the systemic blood pressure, and they reduced the QRS duration. Let me show you one case. So this is a child operated because of Fallot, and look at typical ECG, right bundle branch block, quite broad QRS complex. And this is his ECG when actually paced using an lead in the atrium and the other lead in the right ventricular free wall. And adjusting the AV delay, you could get a QRS complex that is clearly narrower. So we are resynchronizing this heart only by pacing the right ventricular free wall. But it's not always easy with these patients, and there is no patients that actually are alike with each other. Let me show you this very nice paper published very recently by the Hasseguer group, where they actually described that you could actually pace these patients from the right ventricle, but some of them got left ventricular dysynchrony because you're pacing from the right. And they demonstrated that in some of the patients, you might need a biventricular system to actually optimize the function. So I put these two kind of a very recent studies to show that we don't know very well what is the best option, best treatment for these patients. But I think studying each one of them and trying to work out if the left ventricle is still working or not could make a big difference selecting which device are you going to put in. Just the last minute, I want to talk about the results of what we're doing with patients that have a systemic right ventricle or that have univentricular hearts. The numbers for these patients are very rare. So these are the numbers published in these 3-week studies. So you can see very few numbers. So we don't really know how these hearts are activating, and we don't really know the results of this TRT therapy in them. What we do know is that in the systemic right ventricle, which is basically in the setting of a stenting or muster in TGAs or also in CCTGA patients, that the result is actually quite good as well. The ejection fraction gets better and the functional class gets better too. But we don't know what's actually happening in patients with univentricular hearts, and those patients will warrant individual treatment for each one of them. So in conclusion, children are not little adults, and that is important to remember. Adult CRT indication criteria might not be applicable in our population. We need to understand what's going on in those hearts. So you have to use every tool that you've got in your hands to try to understand how the ventricles activate. And the better selection of patients might allow us to improve the clinical response in this group of patients. Thank you very much.
Thank you very much.
Okay, thank you very much. Last speaker is Sarquella Brugada from Hospital San Juan de Déu de Barcelona, who is going to talk about ambulatory ECG monitoring in pediatric population.
Bueno, aprovecho mientras están cargando la presentación para agradecer a la organización, una vez más, contar pues conmigo, pero también contar con la parte pediátrica de las arritmias, que yo creo que ya es una norma y estamos muy contentos desde el mundo pediátrico que ya formemos parte afianzada de este congreso. So, on behalf of our guest, we are going to switch into English, and I think I have the easiest part of the talk, and that's good because it's the last of the Congress, and we will make our best to make it in 15 minutes. So for ECG ambulatory monitoring, we should ask ourselves why we should monitorize our children. Basically because we want to evaluate symptoms that can have a cardiac origin, because we want to do risk stratification for cardiac diseases, for example, or because we want to evaluate or study the cardiac rhythm after a heart surgery or in our congenital heart disease patients. There are several indications. They are already published in several series for ECG monitoring in pediatric populations. I'm not going to go through all of them, but the thing is that there are several types of monitoring, depending on how much time do we want to monitor. We have the classical Holter, 24 hours Holter ECG. We can put it longer, up to 72 hours. And I'm not going to talk about that because we all know that, and that's a classical one, but very useful when we have certain patients that they disclaim or they claim about some kind of signs. Holter can be easily performed, and we can have nice registries like these ones, child complaining of syncopes, daily syncopes, so we can see that having extra systoles, bidirectional BT, so finally having, or at least thinking that we can have a diagnosis of a CPVT in this patient. And there is a non-written rule that says that when palpitations are, patient complains of daily palpitations, even several times a day, when you put a Holter, the palpitations are gone. And we all know that. So sometimes we think that maybe that's not daily palpitations, maybe there's nothing cardiac on that, but we can count on longer devices that can give us some idea of the origin of those complaints. We can go up to the other part of the other extreme of the scale for long-lasting devices, subcutaneous Holters, that we may ask, oh, do they really work in pediatrics? Yes, they do. Yes, we can. because finally an industry that, has thought about children, or thought about to help us with children. We changed the classic reveal to the new reveal link, and I have to say that this has been an enormous change in pediatric field, and that's really important for us. Why? For several reasons. First of all, very important, size. Size is very important even in children. But second of all, because of this monitoring system, this is home monitoring system that we can have all these signals depending on the alerts that we have programmed, that we can receive all these ECGs or tracings that can give us the clue on what's going on with our children. We have to do, of course, in pediatrics, we have to adapt everything, and even the company advises us to put an implant in the mid-thoracic area. Of course, we do changes because we are used to that, and we are very proud to do that. We have to think that they are growing bodies, and we try to have at less scars possible on our patients. So first of all, we adapted this technique to put it under the breast and then the mammary gland, thinking that this mammary gland will grow on age, so we have to be really careful of not touching this area. So even for this congenital heart patient, female patient of course, we have to think that even if she has a big scar here, she was really aware of having another scar, so we had to kind of hide that scar. We use an aesthetic cream. I'm going to go quickly through the insertion procedure, the adapted implanting procedure. We put an aesthetic cream, we prepare the tools, we mount the device, and we do lidocaine and bicarbonate subcutaneously to try to do that in at least no sedation. We try to do just locally anesthetic treatment, no? Let's say. As you can see, we do that in a sterile condition, so we do it in the EP lab, and we try to do as sterile as an implanting technique for any other device, because even we are not going intravenously, we are going subcutaneous, and it has to be as sterile as possible. So there are two different techniques that we have learned after some failures. That one is that big boys or big girls, we don't have problems. We do the insertion technique as the company suggests. But for little children that they don't have that big fatty tissue, we have to just take a little bit of tissue and try to pull up the skin in order to have a nice cut. Otherwise, we can tear the skin and we can have a little bit of rupture. So it's going to bleed a little bit more. So we don't want that bleeding. We have to make sure that the hole is properly open, and we have to go really deep on the skin to try to put the device as far as possible. So then we have to pull up, again, pulling up the skin and pushing it firmly, so we can put the device up on the deepest part. And then we just implant, we twist, as the company suggests, and we implant the device. And we close it using, we don't do sutures, we just use glue, sterile glue. First of all, in a deeper layer, and then second of all, you can see in the upper layer. So finally, we have a scar like this. This is the smallest child we have implanted. It's a 2-year-old child, and it went really well. So at the beginning, we were implanting, as you can see here, under the mammary gland or region, but we saw that for skinny patients that was a little bit protruding. So we changed into a more diagonal position. So we are now inserting the device more axillary, but following the two ribs, trying to fit the device between the intercostal space. So we really hard time to know where is the device, because you cannot even touch it. Of course, we don't go that deeper, so we avoid to touch the arteries and the veins, intercostal arteries and veins, but we try to be really diagonal, really following parallel to the ribs. So what's our experience up to now after, I think, 6 months or 5 months. We've implanted 22 patients. We have a mean age of 10 years old, from 2 to 15. And the indications are syncope in normal hearts, repeated syncope with the rest of all the tests were normal. We have had syncopes in congenital heart disease and some kind of symptoms in patients having sudden death-related syndromes, but that they were not really clear that they were cardiac, but importantly, we have to rule out. So after having had some even EP studies, we decided to implant a device to make sure that those before implanting an ICD, they were really cardiac, or at least to rule out that it was not cardiac. Finally, there are exceptional cases, and that's something completely off-label, that family that having 2 children with long QT, there was a 3rd child who died of long QT, and then we could find out that there was a long QT syndrome in the family. And the mother of these 2 children was in a deep depression, knowing that the remaining 2 children were affected of the same disease that the died one had. So it was impossible. She was not sleeping. She was monitoring the children all night. So finally, we kind of negotiate with her to implant link devices to those children. So this quality of life for this family has changed completely. So it's completely an off-label, so there is no indication, we are aware of that, but it has changed the life of this family, who's continuously coming to emergency department and having this kind of anxious, stressful situation. So these are the signals that we have. It's really nice, clear signals. We can have different examples. I'm not going to go through all of them because of the time, but we can have sinus tachycardia, feeling when the child feels palpitations, we can see that we have sinus tachycardia, so we are like kind of happy about that. But we can also see some kind of duplets and triplets of ventricular extrasystole, but also we can exceptionally use it for patients that are under treatment, under beta blocker or antiarrhythmic treatment, that have a channelopathy, and having after 1 year of peace in our clinical lives, that she has gone bad and in kind of syncopes and palpitations, and it was a way to just find out that even after that's a CPVT patient, even 1 year after a successful sympathectomy, she started again, even taking the treatment, or at least that was what she was saying. So that was an amazing case, and we could have these nice signals here. But we can also have artifacts, and that's very important, and we have to be aware of that. We accept, and we are happy to have those artifacts. In fact, that having an email at 8 o'clock in the morning saying, this child we have registered a bradycardia, it's okay, me or whatever, anyone in the service, we just open the email, we check the signs, the signal, and we see that actually it's an artifact because the QRS is smaller, so it's okay for us. That's not that often, and we accept having these artifacts and having to check or double check those patients. And finally, that's a very important artifact, that if you program the device before inserting it, and that had happened to us once, not twice, just once, we learned that the first email we got from the system, it's an extreme bradycardia that we were really stressed about that till we find out that it was just before the implantation. And actually, that's the first try to put the device in, that we can see all the signals, and then we took it out because it was not deep enough, and then we put it back again, so that we learned that we have to program after implanting to avoid that. And the other thing is that with the machine, we have this kind of, I don't know the name in English, but it's like kind of a recorder thing that it's the most stressful tool for schools I have ever seen, because families tend to give that to the teacher is really scared about that, or the children just play with that, and so we tell the family, just keep it at home, have it at home, but just forget about it. I mean, this this system or this little machine stays at home. It does not go to school. That's also important. And finally, you have a third. We had Holters, which is very short-term recording. We have long-term recording, which is subcutaneous Holter, up to 3 years. But we have the intermediate, which is really useful for us, which came. It's the adaptation of the Holter into a T-shirt or a van. This is a very useful tool that came at the beginning from the adult world. This was a test that we did with these 3 runners. They ran for 24 hours. We monitored them by Bluetooth system, and we could see all the 24 hours race, and we could check and we could just monitor their heart rhythm and if there were any disturbances. So we thought it was very useful. So we adapted to children, and we adapted to Carla. She's our favorite patient. And actually, she's our favorite patient because her mommy is fantastic, and she decided to adapt the tissue to a child. So we talked to the company. I said, it's so easy that we could, this mom could do it, you can also do it. So they came out with a very nice device that it's very useful for these patients that need longer monitoring, longer than a simple normal Holter, but we don't want to implant a subcutaneous device. So we have also nice signals. This was a T-shirt for a 2-year-old with syncopes, and we could find out that she had asystolia that was related to higher vagal tone. So we could find out the cause, but also it's very useful to monitor when we have to titrate the treatment for patients with channelopathies. So we could find out with another CPVT patient that with this T-shirt, with this new device, that we had really nice signals to see if she was having arrhythmias while being under treatment. Sometimes we need just short-term systems, that's cardiomemo, classical cardiomemo, but we have to advance. We are in 21st century, so we have ECG check. That's one of a lot of tools we have in the market, that it's like a mobile system, adapted system that we just put on the chest of the children, and we can have it on our hands, and we have really nice signals. Sinus rhythm, we have ventricular vigeminism, we have tachycardia, which is cut here, we have Wolff-Parkinson-White, we can even see Wolff-Parkinson-White on those, and we can see atrial fibrillation, and actually the company is most dedicated to atrial fibrillation for patients with paroxystic atrial fibrillation. So among all, I think we have lots of techniques, and we have to be proud of how we are advancing in the 21st century, but I think the most important tool we have, and I'm sure you will agree with me, is WhatsApp. WhatsApp is the technology that helps us to be everywhere. We can be on call in anywhere, just having our phone on our hands, or we can help our colleagues, or we can ask for help to try to find out which is the best treatment for our patients. And even it's not a system of monitoring, it's a system of diagnosing, and I think we have to be aware of that. But as I always say, we have to try to find high-quality ECGs, because sometimes we are going to use those ECGs for presentations, so we don't want to see the shadow of who's taking the picture there. But anyway, it's useful. So finally, just to conclude, I would like to say that long-term devices have their own indications. Mid-term are very useful. Mid-term devices are very useful to avoid subcutaneous implantations and to maybe titrate the treatment for certain pathologies. They have different indications, and that's very important. Implant techniques and adaptations of those devices for children, this is a must in pediatrics. So we are pediatricians, we have to have imagination. But thank you guys from industry of having at least thought about pediatric population, which is completely orphan in this world of medical devices. Finally, I would like to say that technology is coming. We don't know what's gonna have, but we have something which is very important, is that colleague, co-workers, that this is the basic of our work, and I think we cannot forget about who we have next to us, and that's our must. Thank you very much.
So thank you very much. We have just a few minutes for some questions from the audience. So I have one question for any of you or all of you. Can you tell us some special consideration in follow-up for pediatric population? I mean, do you think the role for home monitoring system is the same as in adult population? There are specific field in pediatrics where we can use it, or any of you, because it can, yes, I mean remote follow-up for devices, any of the devices you mentioned.
I personally think that the fact that families, they love to see us, we all know that, and the fact that they feel like they see us every day, because if anything happens, we know it. This is something that connects with family, but also they are more relaxed. And even it's something subtle. I think it's very important for them. Those children have been in the hospital for a long time sometimes, and having the feeling that we check their heart, at least technologically, they feel safer, or at least that's my feeling. But the problem is that I'm sure you share that with me, that this time is not count, you know, going into the computer and check all that, and normally you check on your phone, and sometimes while waiting, and this can be really tricky, because at the end of the day you've done a lot of work that's not written, and we are trying to find the best way to organize that. But that's the real truth, that you are checking your phone to see all those signals, and actually you take decisions, and maybe you are in the middle of a conversation and you are opening the chart of the patient. And I think we have to organize on that point. I don't know, Jan, if you have the same feeling.
Yes, I completely agree. I think it's quite reassuring for these families, and we have remote monitoring on all the patients that we can use it on. But you're right, we have a real problem with the data. So much data is coming through, and how do you handle that data? And you know, we're all a bit worried if some data comes through and it's dangerous, and we should have done something about it, but we didn't see it immediately. Something happens to the patient. So I think it does come with it a lot of worries about how we organize ourselves.
Well, first of all, I'd like to say that they were great talks, all of them, and I want to ask a question for Jan for the subcutaneous ICD. Because of your large experience with it in children, I just want to know in which patient you will still indicate at first choice subcutaneous ICD. With the problem that you've had, knowing all the problems, in which patients will you indicate at first choice?
Well, it is a real problem that the very patients that you want to target, the young people with inherited cardiac disease, are often not suitable. So if they've got T-wave inversions with HOCM, or they've got very abnormal T-waves with long QT, it's not always ideal. Some cases it will work, can't immediately rule them out, but there are a lot who represent that false positive group that you think it's going to work, and then they have T-wave oversensing. We have 3 of our group have CPVT. It's not been very good in those patients. In 2 of them, we've had to remove it. But CPVT is pretty bad with all defibs. So the transvenous devices also struggle in that group of patients. So I think they're just a bad group for technology to cope with. We've used it in a Brugada patient, but the dynamic changes of the Brugada ECG can also represent problems. And we've had one patient with T-wave oversensing due to the change to type 1 pattern on exercise. So that isn't without its problems either. So we come down to really congenital heart disease patients. In the UK experience, they were the biggest group who got the T-wave oversensing, tetralogy patients and Epstein patients. So they're not a walk in the park either. But there are some patients, you know, where you just have no venous access, and I think this technology, you know, we shouldn't throw it out. It's very exciting. It's just very new at the moment, and the company are working on altering the censoring algorithm. We've realized that screening tool is not great, and that is going to change, I'm sure. And with all that understanding and with the device getting smaller, I think it will be suitable for patients.
Just one question. I think there is a group as well that might be a good option, which is patients with DCM that have a normal ECG, that have you've got documented tachycardia, or they've got polymorphic ventricular tachycardia. Those patients are suitable. They don't need pacing. They normally are bigger patients, and the QRSs are normally okay with the test. So a primary prevention for patients with DCM might be another good indication.
The worry there is always that are you going to have to resort to CRT
Exactly. And then you
down
need
the
a
line,
transvenous
and then you've got to change the whole system.
We have a question, Dr. Moya.
Okay, thank you for all your presentations. And I have one question for Eric and the other for Georgia. I enjoyed very much. I learned that more and more you are showing us how in younger kids there is more trend now to implant endocavitary in intravascular pacemakers, and not more than epicardial, and both options are feasible, and you showed here that both are feasible and that we have to decide or individualize. Which are the criteria for selecting one or another in young kids?
So when we started, we had surgeons who weren't interested in doing epicardial systems. They wanted to do switch operations, Norwoods, that sort of thing, and the pacemaker was something unattractive to them. At the same time, we had the techniques for transvenous pacing, and so for 20, 25 years, I've been implanting pacemakers in small children. Currently, we have surgeons who are interested, and looking at the fact that veins do block off much more frequently under 5 kilos, we've now taken the view, if the surgeon is prepared to put the lead onto the left ventricle, which may mean a left thoracotomy, or if it's a stenotomy, he still has to get all the way around to the left ventricle, under 5 kilos, and he's prepared to put it on the left ventricle, then I go for an epicardial system. If the surgeon isn't prepared to put it on the left ventricle, then I think there's no particular advantage of an epicardial over an endocardial, and even under 5 kilos, I would still place a transvenous system. Above 5 kilos, we would go for transvenous. That is our approach. It may not apply to all units. I perhaps didn't stress this, but I would say if you're going to put a lead in, you must be prepared to do the extracting yourself. You can't expect to say, I've put the pacemaker in, oh, it's 6 years later, send him somewhere else to be treated. That's not fair on the patient, and that's not appropriate. And I think if you put in leads in small patients, you must be prepared to carry through and do all the treatment the patient needs.
Thanks. And I have a question for Georgia, because you showed here that you indicated some subcutaneous Holter monitoring in some patients with syncope and normal heart. So, as syncope is very frequent in young patients, which are the criteria for indicating ILR in patients with syncope and normal heart?
When I say normal heart, it means with no congenital heart disease. The fact is, it's patient with syncope, and we have done Holter, we have done an ECG, but we have done an EP study, and we could not find anything, and we still have 3-4 syncopes per year, so we end up putting a loop recorder.
Okay.
Any other questions from the audience? Okay, so I think we're done. Thank you very much. We're finished. Thank you very much.
Okay.